Hello everyone and welcome back to another teaching session here at Dr. Coaches. I'm Dr. Carlos Guerrero, a GP trainee here in the UK. Today is our day 9 from the course and we're going to be talking about SimMan. Let's start with what's a SimMan. So SimMan stands for Simulated Mannequin. This station you would have something different from the other ones. You would have an actual mannequin, a simulated patient laying on the bed. Now, this station tends to be challenging and can bring a lot of stress to some people because they might not be used to be dealing with mannequins or simulated stations like this one. But don't worry, we're here to help you at Dr. Coaches. Let's talk about what's the SimMan. What's this simulated mannequin about? When you go into the room, you have to go inside the room and you would see a mannequin laying in the bed. Whenever you see that, you have to know to yourself that you're dealing with the SimMan station. What's this mannequin about? What can this mannequin do? So this mannequin can talk to you, he can blink his eyes, you would be able to listen heart sounds, breathing sounds, feel the patient's pulse, feel the patient's sweat, temperature as well. Now, you can face different sorts of scenarios within the SimMan and different sorts of variations within the SimMan. Sometimes you would only see the SimMan laying on the bed with the examiner in the corner just evaluating yourself. Other times, you would have a nurse who will be calling you or will hand over to you some information. So you would have to interact as you do with a colleague, with the nurse, and also with the SimMan. You have to bear in mind, you would always have to engage only with the SimMan. The examiner is only there to evaluate you. Let's talk about the structure in SimMan. In the SimMan station, as with other special stations, the structure will vary a bit. You will start with your grips, introducing yourself, whether it is to the nurse or the patient, or both. Remember, if there's a nurse, you have to introduce yourself to her, and if there's a patient, always, because there's a SimMan, you'll have to introduce yourself to them as well using grips. How to assess the patient? Initially, you would have to gather as much information as possible using your P3 mouth TOSA on a very focused manner, just taking relevant pieces of information. The likelihood would be that the patient would come in with one concern, whether he's feeling short of breath, whether he's developing tummy pain, and then yourself will have to explore that concern and ask your P3 mouth TOSA on a summarized, relevant manner. We aim to take information in no longer than 2 minutes. And why is it that we just take 2 minutes? Because then, after taking your focus information from data gathering, you would have to jump into what we call A to E approach. The A to E approach, it is meant to review the patient in a very structured, sequential manner from A to E. Why? Because it takes into consideration evaluating first critical organs such as your airway, lungs, and heart. A, airway. What do we do or what do we check in airway? First of all, if the patient's speaking to you, we can assume the airway is patent. That is just at inspecting and listening from the patient. But nevertheless, you would always need to look at the mouth. What for? Whether there's a foreign body, whether the patient has any blood in his mouth, whether his lips or tongue are swollen and causing a potential threat to his airway. B, your breathing. The first thing you will have to do with breathing is recheck your vital signs. What are those? Oxygen saturation and respiratory rate. So, if you have not asked the examiner since earlier in the station, at this point, you would have to verbalize either to your examiner or nurse. Examiner, would you be able to connect the observations machine to the patient? Or you can say, can I get a set of observations for my patient? I would like respiratory rate, oxygen saturation, heart rate, blood pressure, and temperature. Going back to your B, breathing. What's relevant for breathing? Oxygen saturation and respiratory rate. The first thing you will have to deal with breathing is, if the patient is not saturating well, you will need to address this. There is two ways we can address it. One, with 15 liters of oxygen through a non-rebreathable mask, or two, with a venturi mask. And when do we choose which one? If the patient is known to have COPD or CO2 retainer, we will go first with the venturi mask, because that way we avoid the risk of CO2 retention. But if the patient is not known to have these conditions, we can go straight away into putting him in 15 liters of oxygen via a non-rebreathable mask. Now we move into C, circulation. First thing first, as I was mentioning with you, we need to check for vital signs. What do we check in circulation? Heart rate, blood pressure, and not a vital sign, but always to check capillary refill time. Same thing as the B and A. If the vital signs or observations are abnormal or low, we will have to address it and give a treatment for it. So, for example, let's say we're thinking this patient might be developing an infection and his blood pressure is 85/50. What do we give this patient? Fluids. What kind of fluids we can give? 1 liter of normal saline, 0.9% through the vein, right? That's what we give. Remember, on SimMan stations, you acknowledge that there's something going on, for example, low blood pressure. You give a treatment, fluids, and then you reassess. How you reassess? You verbalize either to your examiner or the nurse. Now that we have given a bag of fluids, would you be able to recheck the observations for me, in particular the blood pressure? Because that way you can see, one, how's the patient doing, and two, is my treatment work? Now, other things we can also do on C is gain vascular access. Where do we gain vascular access? Through the vein. The way we do this is we verbalize to the nurse or examiner, would you be able to place in 2 wide-bore cannulas on the patient's forearms for me, please? Why do we say 2 and why do we say wide-bore cannulas? The reason is because you have to bear in mind we're dealing with an unwell patient. We will need to have as much access as possible to try to treat these patients. It is often and common the case that we might need to give 2 treatments through the vein at the same time. So we verbalize gaining access. We gain access, and then from the same access we can verbalize, I would also like to take a set of bloods. And you can say, I would like some routine bloods for my patient, and verbalize what you want. Full blood count, USNEs, liver function test, CRP, or if there's anything else going into your mind, like a possible MI, you can verbalize, I would like a troponin as well. Apart from this, you can also ask for things such as a VBG, venous blood gas, or an ABG, arterial blood gas. You can also mention, relevant to circulation, it's taking an ECG. Now let's move on to our D, disability. What do we check in here? Very importantly, we check for the patient's GCS, Glasgow Coma Scale. We check the patient's pupils, we check for temperature, and we check for blood sugars. Now on our last bit of the A to E assessment is E, exposure. It is required for us to expose the patients to try to look for other things that might be making this patient unwell. As with any real patient that you would do, you would have to ask for verbal consent. Mr. John, now as part of my examination, I would like to expose your legs to have a look at them. Would that be alright with you? Expose the legs, have a look, and cover them back. Same thing goes for abdomen, chest, and part of the arms. Wherever you're exposing, verbalize, ask for consent, go on, and then cover it back. By the end of this station, you might be required to discuss this case or hand over the patient with the examiner. How would you hand over this patient? In the UK, we hand over or discuss patients between colleagues or healthcare personnel using the S-bar method. S situation, B, background, A, assessment, and R, recommendation. Hello, I'm Dr. Kuberu, one of the GP trainees here at the A&E department. I was asked by one of the nurses to come and review John. John is a 72-year-old male patient who came in with 2 weeks history of gradually worsening breathlessness associated with bilateral lower leg edema. John has a past medical history of heart failure, high cholesterol, and ischemic heart disease. On my assessment, from A to E, initially he was struggling to breathe with an oxygen saturation of 84. I put him on 15 liters through a non-rebreathable mask. On E of my exposure, I noted that John had bilateral lower leg swelling and reduced bilateral air entry, crepitation sounds, and I initiated treatment with intravenous diuretics. Looking into John, I believe he's having an exacerbation or decompensation of his heart failure. What I would like to do for him is, I would like to admit John to the hospital. I would like to chase the bloods that I've taken for him, FBCs, USNEs, CRP, renal function test, BNP. I would also like to chase and take a chest x-ray to have a look at his chest. I would continue with IV diuretics and oxygen while he's improving his saturation. And I would need to promptly discuss this case with the cardiology team or the medical. That's a wrap for today's teaching day. Remember, if you happen to have any questions, concerns, or doubts, write them down, ask us on our Telegram group, or raise them up on our feedback day, practice day. Thank you for watching and take care, and see you till the next teaching day.